I would say give it another. What do you have?
Is anyone joining remotely?
Yeah, you have about 6 people online. Yeah, Cheryl. Oh, you want to see sorry. This should be fun. I like this because the research is, I think, really interesting. But it's non-overwhelming. The data is all part of the enemy data, nobody had like a mega data. You kind of sort of leverage what you have. Yeah, I'd love to hear about that. Well, you know, right now, you want to just pop over for half an hour and just talk about it. That's great. Yeah, that sounds great. Good.
Is this what we've been at?
He's taking me to an Indian restaurant.
In the Bronx?
No, around here somewhere.
Excellent. Try to go.
Get one, get one. Okay, let's start. Welcome to the second session of our fall weekly public health seminar series. And this week's speaker is Dr. Adam Block. As most of you know him, I will not go through his bio. He is our health policy expert, has a research interest in insurance, individuals' choice in accessing healthcare. So the topic of today's talk is starting a health insurer is hard, evidence from New York City. Before I give the floor to Dr. Block, I would thank Malati for bringing snacks today. Today is an Indian festival called Ganesh Utsav. So she's kind enough. Why is she? She brought the snacks and she's late. She's a first-year doctoral student. So I also would like to draw your attention, since our dean is here, to draw your attention to 2 speakers who are coming in the next few weeks, so that you can put it. Oh, there is Malati. Malati, we were thanking you for being so generous in sponsoring our snacks. And did I say it correct? Today is Ganesh Utsav.
Ganesh Chaturthi.
So he is the god of wealth.
No, he's the first god to pray.
Thank you. Okay, so the speaker for October 3 is Dr. Kennedy, who is the director of New Haven Health Department, Connecticut. And October 10 is Dr. Maritza Bond, director of Bridgeport Health Department. And October 24, Dr. Frank Del Carrillo, director of Essex County Hospital Center, New Jersey. So I would like to put it on your calendar, these 3 special speakers.
Also, 17th is going to have a speaker too.
Yes, we have speakers every week anyway, except next week is a holiday. But these 3 are kind of health commissioners and health directors, so I wanted to draw your attention.
Can I just add one real quickly? We have been in discussions with the Harvard School of Business, and they're sending a speaker at November 28th.
Oh, I don't know the final date, but I know he's going to come in for an evening.
Dr. Tom Feely, who is part of the value-based healthcare group led by world-famous economist Michael Porter. And he'll be here. I don't have the location. He'll be in the bigger room. But he's coming down from Harvard. He's going to be working with us on a project in 2019, looking at value-based healthcare and value-based payment for healthcare. November 28th. I'm part of the date.
I would like to know exactly when, and I will not try to organize these events. I'll talk to you.
Okay.
My November 2018 calendar is not thoroughly envisioned yet.
Yeah, it's the week after Thanksgiving, yes. Yeah, no, I just want to say, so I was so impressed with this because the Harvard Business School sought us out, and if I don't really follow business school stuff. It's not really my area, but I know one professor in all of the business school world, and it's Michael Porter. And it's because when I first started out as a consultant, we learned Porter's 5 forces models, which is strengths and weaknesses, SWOT analysis, opportunities and threats. That's from Porter, who never did healthcare, and all of a sudden 10 years ago, he decided that this is going to be his thing because he couldn't figure out how this crazy industry worked. And so now
he got a health insurance bill or explanation of benefits.
There are lots of people that it happened to. So I'm going to talk a lot about Oscar, and if I forget to mention, that's how Oscar basically started. Was that they got a health insurance bill and they couldn't parse it out, and they came from a tech company background, and they're like, it doesn't have to be this way. Whereas the rest of us, certainly myself, who's been working in health insurance a long time, is like, it has to be this way, which it probably doesn't. So there are some opportunities here, but this talk is about why it is this way, because starting a health insurer is hard. You don't really hear of startup health insurers. You hear of Blue Cross plans and Aetna plans that have been around for 150 years, United, and there are a couple of little ones that have popped up, but no more clearly than in the year 2014, when the Affordable Care Act really kicked in. The Affordable Care Act, which is one of my areas of expertise, passed in 2010, but all of the tax credits and the Medicaid expansion, but really the tax credits that went to these new things called exchanges, which is just a website, by the way, they did not start until 2014. And so what you saw is an influx of health insurers that's actually started up in 2014. And so that's what I'm here to talk about, because now it's 2018, we're in plan year 2019, people are going to be enrolling in 2019, and we're down the road a little bit, and a lot of interesting things have happened that nobody really expected to happen. So one thing I'm going to talk about is evidence from New York City as to what happened in our specific market. So I'm going to give you a little bit of background. I'm going to talk a little bit about New York's individual market. It's had historic problems, but that also made it a good opportunity and a good opportunity for a case study. The managed care market in New York is robust. Anybody that's taken the subway has seen advertisements for tons of managed care plans. Anytime you see sort of a younger person with their arm around an older person, that's generally not for like a provider or anything, that is for a managed care company. And so there are tons of these companies all around New York City. And I'm going to give you a broader market overview. Then we'll talk about the methods of the research, because this was original research. I'm not just going to talk about policy or background. This was something new that I did. And then talk about some of the results and what some of the basic conclusions are. And I also want to start off by saying that I first submitted this proposal to Academy Health, which is a national health policy conference that I go to in February, and I did a poster presentation. So if you go outside my office, that is all this work. It was pretty well received there, and so I submitted it to a couple of different journals. Gotten rejected from many of those journals, but it's now up for review in a journal called Managed Care. So hopefully we'll be seeing it in a publication not too distant future. And Shruti actually helped me way back about a year ago doing some research assistance, pulling up some of the Department of Financial Services data. So thank you, Shruti. Okay, so New York City is a great market for startup insurers, and here's why. So first, there's a lot of demand, right? And how come there's a lot of demand? A, there's a lot of people, right? And when there's a lot of people, there's a lot of demand. We don't necessarily care about per capita demand. What insurance companies care about is how many people are there. So if there's a lot of people, there's a lot of demand. But not only are there a lot of people, New York City is sort of a haven for startups, financial services, small law firms. So there's a lot of big financial services companies out there, but it's not like a place like, let's say, Washington, D.C., where I guess there's a lot of people work for the federal government or they work for big contractors, things like that. In New York, there's little accounting offices, there's artists, there's people that make their own coffee, there's all sorts of stuff. And all these people are not only just self-employed, but they are also relatively well-to-do. So they want to go out there and they want to buy health insurance on the individual market, making it a demand-heavy, a place where there's decent demand. Another interesting thing about the market is regulation. This is called, so in most places there is age rating, meaning that if you're young, you may pay $200 for health insurance, and if you are, let's say, 64 years old, just before going on Medicare, you may pay $600 for that same policy. Not in New York. Everybody pays 300, would pay $300 or $400, regardless of whether you are 20 years old or 64 years old. Supply. There's actually a decent supply. So this is what I was saying about all the managed care plans that are all over the place, and there's a broad supply because New York is a broad state. So there's places that there are plans in, let's say, the Albany region that may want to come down to the New York City region if the market is right. So there's a broad supply that is competing for market share, as opposed to some other areas where you just have like one big Blue Cross Blue Shield plan. So for example, Alabama is one that I've been shocked about for years. There's Blue Cross Blue Shield of Alabama. It's actually a really well-run plan. However, it has 90% of the market. 90% of the market. That is not a competitive market by any stretch of the imagination. New York City, I think most people would consider a competitive market, and which means that you're competing on price, you're competing on quality, people can change plans throughout the year. So it is a well-structured competitive market. And then the last piece I would say is capital. Because New York City is the financial center of the US, if not the East Coast, if not the US, if not the world, there's a lot of money flowing around. So if you have a startup and an idea, often you don't need to first you may have some connections where you can get money funded relatively easily because you know people in finance, and you don't have to fly across the country to go to a meeting. You can just go across the street to Wall Street. So because of all of these reasons, I think that New York is a really good case study in the individual market, and also presents a large opportunity to study what happened in the individual market. So what happened? Well, in 2014, there were 3 commercial plans, which means that plans that basically serve commercial markets, people that are getting employer-sponsored coverage or are paying for coverage themselves. There are 4 Medicaid plans, which means that people in Medicaid, is everybody familiar with Medicaid managed care? I'm going to tell you what it is. So Medicaid, so everybody knows what Medicaid is, at least everybody that took my class better. So Medicaid is the plan that helps the poor pay for medical care, right? And in New York State, starting in 2012, they converted Medicaid, which was formerly everybody basically had an insurance card from the state, into a program where you went into a private plan. Health First, Fidelis, Metro Plus, Affinity, there's a whole bunch of private plans out there. And so there are 4 private plans of these Medicaid plans where most of their membership is in Medicaid that went into the individual exchange market. And then there were 3 startup plans. And I'm defining a startup plan as a plan that did not have any membership or any individual market membership prior to the year 2014. 3 plans that said, we are starting an individual license. We are getting our license for the first time to sell insurance, and we're going to sell insurance for the first time. They started basically from nothing. By 2018, this year, only 6 of those 10 plans remained. So 4 of them basically went out of business or exited the market, and others also had some financial problems. However, what's interesting is that of the plans that left, so here are the startup plans, and I'm going to use this color scheme going forward. Yellow is for the startup plans. And I'm doing what I have told many of my students not to do, which is put way too many words on a page. But I had this all condensed in my poster, and it is really hard to parse out, so I'm actually going to talk through all of these points, and I can make the the slide deck publicly available. But what's important, I think, here is to definitely get the color, which is that anything in yellow is going to be a startup from here on in. Anything in green is going to be a Medicaid plan, and anything in blue is going to be a commercial plan. And what you can see is that that all of them are very well represented. So the 10 plans, Health Republic was what's called the co-op. It was help. There was funding from the Obamacare for it. They gave loans, hundreds of millions of dollars in loans to start up this new plan, Health Republic. And what you can see is what happened to it. New York State saw they were losing so much money. I can't even tell you how much money, so much money, like $1 billion, that they forced their exit. They were in November 30th of 2015. There were plans to exit at the end of the plan year, December 31st, and they said, you are hemorrhaging so much money that you need to get out now, you need to get out now. And they had about 17% of the market during the time that they had enrollment. They don't have enrollment anymore. Care Connect, I was a Care Connect member. That is Northwell. That is what Michael Dowling, when he came here and spoke to us a year ago, spoke about. They had just exited the market when he came here to speak to us. He actually spoke and talked about something that he said was one of the leading causes for his exit of the market. He just published an article in Becker's Hospital Review called The Anatomy of a Difficult Decision, which I assigned to my health economics students this semester. It was a great article about how he made the decision to exit the market, but at the end of the day, he exited the market. They said, okay, Care Connect is done, no more enrollees. We are done as of December 31st, 2017. And Oscar. Oscar is a pure tech venture. It was started by, you guys all know who Jared Kushner is, president's son-in-law, right? Josh Kushner, his brother, is one of 2 or 3 founders of Oscar. And it's a tech venture based on, it was actually named after their grandfather, Jared and Josh Kushner's grandfather, Oscar. But basically, it is their objective was to apply some of the Silicon Valley simplicity and friendliness to health insurance, which is an overly complex industry. Whenever you get a bill, it's impossible to understand what it says. So their goal was to say, we're not going to do that anymore. We're going to make this straightforward. If it's expensive, it's expensive. We're going to make it straightforward. And I'll talk to you about what's been happening with Oscar for the last couple of years. And then the Medicaid plans, one Medicaid plan Affinity left, but Fidelis, Health First and Metro Plus still in the market, and Emblem, Empire, and United all still in the market. So that's an overview of what the market looked like in 2014 and now in 2018 going into 2019. Stop there. Any questions? Thoughts, comments?
Just one thing. At the bottom, United, is that really 2% market share?
Yes, and there's a very good reason for that. So, and I'll give you the outside baseball and the inside baseball. The outside baseball is, if you look, and I actually wrote a Health Affairs blog post about this in 2015, but their premium is like mountains above everybody else, like in some cases double. So you only go to it. So basically they view themselves as a premium product. And so if you really need their network, you'll go to them, but otherwise they won't. The inside baseball I heard from at this health policy, you don't hear it at a meeting, but at a lunch, one of the actuaries, he basically said that the CEO of Health United said to the chief actuary, you better not lose a dime on this product, otherwise you lose your job. And so they priced it incredibly high, and as a result, right, markets work. People went elsewhere, and they said, no, you get 2% market share.
Were they not maybe somewhere around 20% or 30% at one time?
In the individual market in New York.
The individual market.
This is only in the individual market, not in the fully insured. I mean, this is only the exchange. And it's because their premiums were insanely high. And I have a premium slide later that will only show recent premiums, but if you look at them way back in like 2014, they were double. Okay. So the methods. So what did I do? I've just told you the background, but what did I do? So I'm going to tell you what the data source is. I'm going to tell you what the financial metrics we analyzed were, and I'm going to tell you about a little bit about risk adjustment data and reinsurance, just what they are, because they actually do play a role in this. It's hard to avoid them. and they're relatively complicated insurance concepts, but they're really important because Michael Dowling himself, the CEO of Northwell, now is well-versed in risk adjustment. And so if he is well-versed, if he runs 26 hospitals, if he's well-versed in risk adjustment, well, then it makes a big financial difference. So I think we can spend a few minutes learning about it. And then we'll go through some of the results and some of the conclusions. So where did I get all the data that I was going to use? I wanted to do a financial analysis and say, okay, what caused these startups? What's different about these startups from everybody else? The startups all failed, and Oscar did not fail, but Oscar has lost $250 million in the last couple of years. In the last 14, 15, 16, 17, they lost $250 million. That's a lot even for a tech startup to lose. And they have begun to turn it around, maybe, possibly. I don't quite believe it. I'm not a believer yet that they can turn it around in this market. But the fact is that they have lost $250 million. How do I know that? Why do I know that and you all don't know that? So Shruti might know it because she dug into the Department of Financial Services, New York State Department of Financial Services, which is who regulates all of the insurance for the state of New York. They require every single health plan submit a quarterly report that says how much money they made, how much money they have, what their enrollment is, all sorts of pieces of information like this. And so I went into those financial reports and pulled them up, and then they're in PDF, which is terrible. So you can either convert them out of PDF, or you have to type it in yourself, or if you're me, you can ask someone in this room to type it up if you have an RA. So that's what I did. Initially, that's what I was planning on doing, but I found that that even didn't have enough information for me. So I got some supplemental information. I'll tell you where that came from. It came from Exhibit 17 of the rate submission. So in addition to submitting quarterly data, they submit annual data every time a health plan sends to the Department of Financial Services, to the Department of Insurance here. Every time they send them a rate, we are going to charge $300 per member next year. They have to submit that to the Department of Financial Services, and the Department of Financial Services says yes or no. And so what gets actually sent to them? Well, it's like a 10-page document that's like a memorandum saying what it was last year, why they had to increase it. But then there are some exhibits. In fact, there's something like 25 Excel exhibits that go along with this. And so I looked through all of the exhibits and tried to find what had actually relevant information. If you dig through all of it, it's something like 150 pages. So I found Exhibit 17, which actually had a bunch of information that I thought was really useful. And so I pulled out that information and then took it all out and compiled it. So it didn't take me that long to put together this paper. I mean, by not that long, I mean about a couple of weeks or a month. The vast majority of time was spent, and it wasn't even downloading this information, it wasn't even finding it. It was really pulling it out, extracting it, and compiling it, and making it organized into like a simple data set that you can then run either pivot tables on or reasonable tables on. What I will say about the data is that the data is individual market only. The Affordable Care Act exchanges are for the small group market and the individual market, but I wanted to narrow it down to just the individual market. The individual market, has by far more enrollment, and I thought it would be way simpler rather than looking at two markets at the same time. So this is only individual market information. The only thing that wasn't included in those rate submissions, ironically, even though they're rate submissions, is the premium data. And the reason that they're not included in the rate submission is because they submit the rate to the state, and the state says, we're going to cut you by 10% or 15% or 20% or 0%. So then the state puts out here is what the rates are. Every year they put out actually a really nice and clear Excel document that simplifies what the premiums are by region. And so I used that annual submission from the state to get what the premiums are, because I'm going to go through premiums towards the end. So what did I pull out? I pulled out total incurred claims. That means how much money did the health plans spend on medical claims. How much did they send to Westchester Medical Center? How much did they send to Montefiore? How much did they send in their contract to Dr. Blanchette, right? How much money did they spend? And then it also says how much is in reinsurance, how much is in risk adjustment. These are separate line items in the financial report. What did they spend on administrative expenses? Everybody know what a health plan administrative expense is? So does Blue Cross have a building? That's an administrative expense, right? Does Blue Cross have computers that process claims? Does it have people that work on processing claims? Does it have a call center? All that stuff is administrative expenses. An administrative expense as well as profit. Anything that is not a medical expense is an administrative expense for a health plan. And then the last piece of information I got, which I said was from a separate source, is premiums. I got premiums from a completely separate source. And premiums, just so we're clear, is what you have to pay. If you want to enroll in this plan, this is what you have to pay. And this is the base premium, it's completely separate from, right? The Affordable Care Act says if you're below 400% of poverty, you may be eligible for a tax credit. Forget about that. If you're not eligible for a tax credit, this is what you have to pay. Okay, so I just want to be clear what risk adjustment is, because it actually is a big deal. Risk adjustment is a mandatory program that started with the Affordable Care Act. Actually, it's been in Medicare for a while, it's been in other places, but it hasn't been in the individual market. So it's a mandatory program where if you have sick people, you get money from it, and if you have healthier than average people, you put money into it. But the government says what the formula is for sick or healthy. And then at the end of the year, CMS, right, the part of HHS, puts out a giant list, a 50-page list of every health plan in every state and what they owe and what they don't owe, right? And you get this list and you're like, am I going to owe $50 million? I mean, there are numbers in that there are 50, 100, $200 million. So that's what risk adjustment is that it says that you're either going to get $30 million from all your peers, they're going to put it into a pot and $30 million is going to go to you, or you're going to have to pay $50 million or $5 million, and that amount is going to go to all of them. What I will say is that new health plans have made lots of complaints that they are at a disadvantage in evaluating health because they have a lack of experience. They've complained, we are getting basically screwed because we are not very good at risk adjustment. Michael Dowling said that at his talk a year ago here. And he said it again this. I have a slide on that, so I'll talk more about it. Reinsurance is, and the reason I say this is because these are line items on the financial services that you have to parse out. So reinsurance basically means that if you have a very expensive, let's say NICU baby, some NICU babies can cost, I mean, a bunch at $1 million. Is that right? It is not crazy for a NICU baby to be in the hospital for 16 months and cost $1 million, right? Now, small health plans can't afford that. They know they have the risk of it. So what they do is they say, okay, we're going to go to the Royal Bank of Scotland, which has a lot of money, and say, you know, if anything over 200, I'll pay you a premium. Anything over $250,000 you pay. So there was a formal program for that said that anything over $250,000, the federal government was going to pay that to health plans. And then so that's another line item. It's another place for the health plan to get revenue if they have very expensive patients. And so reinsurance basically was something that they made mandatory to protect insurers from high risks and potentially from going out of business from just getting a couple of rare instances where they have extremely expensive patients. So let's go into some of the results. So the research question here is, why are startups going out of business and everybody else isn't? Right? That's the basic question. What is happening there? So what I want to show you is some data that shows how badly the startups are doing. This shows you how badly the startups are doing. This line up here, this is zero. This means you made no money. This is how much money Health Republic, the co-op, lost. And this is how much money the Oscar lost in the first 3 years, and this is how much money CareConnect lost. This is per member per month. So for every member that they enrolled, Oscar enrolled, they lost $182 a month. Just to give you some perspective, a person's premium is only about $400 a month. So for everything that they were enrolled, every person they were enrolling, they were losing $182 a month. You can see how much bigger these numbers are than all of the other numbers. And in fact, right, so Emblem was losing a decent amount of money per month. But all of these other guys, some of them were actually making money, including Fidelity. Health First, sort of breaking even. So you can see how much bigger the yellows are in terms of losing money. They really were losing way more money than everybody else. So the open question is, what is driving disproportional losses for startups? And so I'd say, okay, well, what are the options here? What are the potential reasons? So, and there are a bunch of like very good business reasons why this could be happening. One of the very good business reasons is that it's expensive to start any business. If I start up a pizza place, I got to buy pizza ovens, I got to buy aprons. It's not just that, you know, my neighbor down the road, they just have to buy dough and sauce and all that sort of stuff. I have to buy all of the startup expenses. And so if you're starting up a business, if you're starting up a health insurer, you have very big capital expenses. You have to develop a network, you have to hire all your staff, you have to buy your computers, buy your claim system. There's a ton of stuff that you have to do. So that could be one reason that these startup insurers are doing so badly in their first 5 years. That is a perfectly legitimate reason. That is a part of the, right, that is part of the business process, and they should be pricing that in or expect to make profits in the long run, right? So maybe that's the reason, and we're going to test that. Blame risk adjustment. That's what a lot of people seem to do. They say that the risk adjustment system was not fair. I lost a ton of money on it. It wasn't my fault, and I got screwed, right? So maybe that's what it is. Maybe you have a higher network cost. Maybe there's something about being a startup insurer that means that you have a higher network cost. One reason that you might have a higher network cost is because you have your network is, you don't have any, basically the network negotiation. How you contract is, it says, I can bring you 10,000 patients. I can bring you 50,000 patients. I can bring you 100,000 patients. If I bring you 100,000 patients, why don't you take your price, which was $100 per patient, and knock it down to $90? A new plan has 0 patients. So the providers may not be saying, okay, knock it down to $90. They may say, no, you're not bringing me any patients. You're not giving me any volume. You get the list price. That may be something that happens, right? When you go to Costco, right? I went to Costco over the weekend, and you can buy a vat of ketchup, right? For 10 cents, what amounts to 10 cents an ounce. And if I buy my vat of ketchup at 10 cents an ounce, well, I have to buy 5 or 6 pounds of it, right? Then I get the 10 cents an ounce. But I can't walk in there and say, you know, I'd like an ounce of ketchup at 10 cents an ounce, right? They're going to say, no, you don't get to buy it at that. If you want to buy 1 ounce of ketchup, you got to pay $1. So high network costs, basically all of these startup plans have low volume, and it's possible that they're not getting the same network discounts as some of the more experienced plans are. Another reason is, well, maybe all the sickest people flock to Oscar or CareConnect or Northwell, right? And they lost money that way. They just had sick people. And the last possibility is that maybe they just set their premiums too low. They lost a bunch of money because they were trying to get market share and they had a super low premium. They didn't get any revenue, and everybody else was charging $400 for the product, and they were charging $300 for the product, right? And that's why they lost money. Certainly possible that that happened. So I'm going to go through all of these and tell you which one I think it was and why. So the first thing is risk adjustment. Was it risk adjustment? And I'm, again, going to not follow my own rules of presenting, which is I gave you an incredibly complicated quote. But this is from Michael Dowling. This is from the article he wrote in Becker's Hospital Review just about a month ago. Basically, what he says is that it became increasingly difficult to ignore the downstream effect of the risk adjustment program. Basically, it was designed to prevent cherry picking and health plans from getting the healthiest enrollees and trying to get the healthiest enrollees. And what it ended up being was that the Uniteds of the world were basically really good at risk adjustment, and his group was not very good at risk adjustment. As my old boss said, he said they brought a knife to a gunfight, basically, when it came to doing this coding. And so, but this is a real possibility. So we're going to take a look at the financial, right? So this is what they said. That doesn't mean that that's what happened. This is what they believe happened. So we're going to look at some of the finances behind it. And then Oscar, CEO of Oscar, said something very similar. The reality right now is that risk adjustment promotes better risk coding as opposed to better risk management. A little more diplomatic, but basically he was saying is we are taking it on the chin in terms of risk adjustment, and I blame risk adjustment for a lot of our losses. This is risk adjustment, right? The exchange, the financial, basically Exhibit 17 requires that you submit in how much you paid in risk adjustment. And this is what we see. What we see is that these startup health plans, particularly CareConnect and Empire, they were paying in a lot of money. They were paying in $60 a member a month and $57 a member a month. When they pay in that much, so they paid in a lot, but the average amount that somebody paid into risk adjustment was 54. So they weren't that far off of the average. And in fact, the guys that were paying the most into risk adjustment were Metro Plus, Fidelis, Health First, Affinity. These guys were all paying in more. These guys some of them ended up in the black, making money, even though they were paying in more. So how could risk adjustment be the cause of the failure of these two health plans when these Medicaid plans were doing just fine and paid in more? So therefore, I don't think it could be risk adjustment. I also don't think it can be that they had a sicker population. How come I don't think it could be that they had a sicker population? Well, it comes back to this. Comes back to here. They were paying in for risk adjustment. If you're paying in for risk adjustment, by definition, you have a healthier than average population. So you can't tell me that you're both paying in for risk adjustment and complaining where risk adjustment payments are so high, but saying also you have a sicker than average population. The two are mutually inconsistent. So therefore, we've eliminated two of these possibilities. You can't blame risk adjustment, and it's not a sicker population. So then we said, okay, well, what about administrative costs? These are startups, very expensive to run a startup. Maybe they'll be competitive over time, but they're not competitive to start with. So what is the difference between the administrative costs of these startup plans and everybody else? Were they way out of league? Were they way more? And the answer is, well, we can see here. The administrative costs were more. Look, Oscar's the highest at $111 per member per month. Health Republic is second highest. CareConnect at $71. All above the average, all pretty high. But if you look at the average, it's not like these guys, it's not like you're comparing who's the most and that's all that matters. What matters is what is the difference? If the second most is only $1 less than you and you're losing $100 a month, well, only $1 is caused by the fact that you're a startup, right? So what you see here is you see that the startup administrative costs were $65 per member per month. So they're higher than everybody's, but they're not that much higher than everybody's that you can purely blame it on administrative costs. And I know this is a little bit abstract, but I'm going to quantify it in the next slide. But not before I tell you that it can't be administrative costs. So here's where we quantify it. All the solid yellow lines are lines that you've seen before in that first graph. This is the exact same graph as that first graph. If you forget about all of the I guess what do you call it? Shaded lines. So the solid lines are, this is the straight up, this is the net profitability per member per month of all of these health plans. You've seen this before, and you can see all of the startups are all the way on the right. They have the lowest profitability. They are losing by far the most money. So what we did was we did two things. One, we assumed risk adjustment was zero. We took risk adjustment out for everybody. And then we assumed that everybody had average administrative costs. We said, forget about administrative costs. Whatever the average is, you all have it. And then we tested their profitability again. And what you still see in all of the shaded ones, is that basically these yellow guys are doing worse than everybody else. Negative $83, negative $86, and a whole bunch of these shaded guys over here, they're doing better after you take out those averages, but these guys are still doing very, very badly. So if they're still doing very, very badly, then it's not administrative costs. It's not risk adjustment costs. It's not a sicker population. So what is it? Well, one thing is it could be premiums. One thing is it could be premiums. And so I looked at the average silver premium between 2014 and 2019. This is the sheet that was published. Not this sheet. I just transferred this from a sheet that was published from New York State. And you could see Dean Ambler, you said, we asked about the United. Why do they have 2% market share? Look at that, $579, whereas the other guys are sort of bunched at the bottom, right? They are a premium product, and they have no market share as a result of it. And I'm pretty sure the actuary kept his job. And so if you look at the premium relative to the median price, the middle product price is $414. And what you can see is that these guys, they are not underpricing relative to the market. Health Republic is 0.5% lower than the median. This Care Connect is 1.7% lower than the median, and Oscar was actually 8.6% higher. So they are not underpricing. They're pricing right in line with the market, which is fine, but it means that having extraordinarily low premiums is not a reason. So what's left? Well, what I believe is left is network. I think that these guys all had high network costs. They had extremely high contracts for the reasons, the perfectly reasonable reasons that I said before, which is that the network basically, the contracts came up and Oscar went and they said, well, right, Montefiore or Westchester Medical said, how many people are you going to bring into my organization? And they said, I don't know, somewhere between 1 and 10. And they said, okay, well then you get list price. You don't get any kind of discount. Blue Cross, how many can you bring into my organization? 10,000. Okay, we can negotiate a discount there. So I think it's because of network costs. So discussion. So a couple of possible reasons that startups lose more money than other plans. Startup patients are sicker. Well, they perform poorly on risk adjustment. That indicates their patient populations were healthy, right? So we don't really think that it can be that the startup patients are sicker. It's mutually inconsistent that you both paid money into the system, into the risk adjustment system, indicating you have healthier than average patients, and you can claim that your patients are sicker than average at the same time. It's also possible that medical management was less effective at startups, right? Startups have less experience and they have to pay for care management, like nurses that come to your house and stuff like that. But in reality, medical management is only a tiny portion of revenue. It's, you know, when it comes particularly for a population like the commercial population, which is relatively healthy, if you're talking about the over 65 population or the Medicaid population, maybe it's 2 or 3%. In the individual market population, it's like 1%. So the fact that one is doing it really well and another is doing it, I don't know if anybody is doing it better than the other. I'm just coming up with ideas. But even if one was doing it great, all the startups were doing it really badly, and all of the experienced health plans were doing it really well, it's only going to make about a 1-point difference. Networks at startups are more expensive. So to me, this is by far the most plausible of the arguments. And so the conclusions are that startups perform worse than other health plans in New York City in 2014, starting in 2014. In fact, there was only 6 of the 10 health plans that started out in New York City in 2014 that are still going in New York City. Poor performance and risk adjustment and high administrative costs, they are part of the issue, but they are not the entire issue. They do not solely explain why startups had poor financial performance. To me, it was high-cost contracts, in particularly MagnaCare. So MagnaCare, and this is a little bit of inside baseball, but MagnaCare is what's called a rental network. They have a set of contracts, and if you pay this company called MagnaCare, you can access those contracts. Starting a network is actually really complicated. You have to have a ton of contracts in place. You have to have probably thousands, thousands of doctors and hundreds of individually written contracts in place to do it. It's, to me, the hardest part of starting a health plan. And so what did these guys do that they wanted to start up very quickly? They said, oh, we can't do all of this. We're going to go to MagnaCare. So they went to this company called MagnaCare. MagnaCare has expensive contracts and charged them an arm and a leg for it. And what happened? They lost a lot of money because they kept their premiums low and they were paying very high rates. So the network contracts are a key driver of financial performance. And and there were three startups out there, right? Oscar used MagnaCare, Health Republic used MagnaCare, and Northwell, CareConnect did not, because Northwell is its own network, right? It was basically its own network. What's interesting is that Oscar ended its they saw this, and they ended their they had a 3-year MagnaCare contract, 2014, 15, and 16, where they lost $180 million. They lost another $60-something million in 2017, and in the first half, I just saw their Q2 results. In the first half of 2018, they've actually shown a small profit for the for the first 2 quarters of 2018. I'm still a skeptic. I actually still don't think they're quite there with the profitability, but they're certainly reporting it to the Department of Financial Services. There's a lot of sort of shenanigans that you can play with the numbers. So I don't know if they have or not. I can only tell you what's been reported, but there is an opportunity to shift money from quarter to quarter to show profitability if you want to. So my experience, my conclusion is that network contracts were the driver of startups going out of business in New York City in 2014 to 2016. All right. So that's the end of my slides. Do you guys have any questions? They wrote that they started going one by one, and they specifically said, if you look at their any sort of, not press releases, but like interviews that they've done, they went one by one to a couple of different hospital systems. And a lot of these hospital systems, right, like Westchester has a physician network associated with it, right? It's hospital-associated physicians. Often there's an additional IPA that wraps around that as well. So they said, okay, we're going to take a couple of these guys and go to, I think Montefiore is one of them, and a couple of other ones. They're going to boot New York Presbyterian, the most expensive one, from their network, and just use those. I think they may have even booted Northwell. So they were very selective with their network. That also gets them a little more leverage if they tell, let's say, Mount Sinai, like, hey, Mount Sinai, not only do you have access to all these members, but they're not going to go to NYU. They're not going to go to New York Presbyterian because they're all out of network. So it allows them to get a little bit more leverage.
So with all these startups, the ones that went with MagnaCare, I presume that it was a temporary solution. They assumed that later on they would move away.
Yeah.
To get going, they start with.
I'm guessing that that's what they, I mean, I don't know, but I'm guessing that they did not have an intention to continue to rent the MagnaCare network in perpetuity. Although the MagnaCare network is, right, there are lots of unions that use it. It is not just run by these two health plans. They're not the same business, right? There are lots of union plans that use it. So like, there are plans that use it, but many of those plans don't have as competitive market for premiums, where here you can see, you can see just how competitive this market is, right? This is a dollar amount that you're looking at. And even if you're getting a subsidy, you are not getting a percentage of this. You are getting, let's say, $100 a month. So if you choose this, you're paying $270. If you choose this, you're paying $294. If you choose it, right? You're paying every marginal dollar for the plan that you select, you are paying. So you care about premiums. Jade, go ahead.
So when all these startups shut down and you said you were with CareConnect, it left a bunch of people without insurance. I'm sure it didn't happen all during the enrollment period. So
it did happen. And so when they shut down, so here's what happened. I can tell you what happened. So there were a couple. Most of them had what I would call an orderly shutdown, which is that they end at the end of the year, and then you have your open enrollment period, and you just can't sign up for them anymore. So everybody has to sign up for a new plan January 1st every year. Now you can use your same plan if it exists. If it doesn't exist, you can't, right? So that's what happened. The only weird thing was when Health Republic went out on November 30th, and they had 40,000 enrollees, and the state said, this is so bad that we have to kick these people out a month early, and they got arbitrarily distributed into other plans, the members. That's what ended up happening with them. And that happens in Medicaid markets as well, sometimes when plans go out of business. Yeah.
I'm just curious, this set of plans, when they exited the market, were they audited in any way? Because no one could just start up a business, get all the people enrolled, and then after a couple of months, exit the market and you say they are losses and they can't continue. So
Yeah.
they get audited.
So yeah, they are. I mean, that is the job of the Department of Financial Services to make sure that the health insurance company takes in enough money to pay all of the claims that they have to pay. Because you take in the money at the front end, and then you got to pay it at the end of the, let's say, right? You take the money September 1st, you got to pay the money September 30th. Now, maybe you didn't take in enough money to pay in September 30th. That's exactly what happened with Health Republic. Now, to me, whose fault is that, right? That's the Department of Financial Services. I mean, it's the company's fault. They went out of business. So this is the Department of Financial Services' fault to make sure that these companies have enough money. In addition, there's something called reserves, where an insurance company doesn't just take in enough money to pay their claims. They take in enough money to pay their claims plus a little bit more in case something happens. So it's basically like an emergency fund, right? Like if you run a household, and if your car breaks down, you're supposed to have some emergency money. You're not just supposed to run a zero balance on your, right, in your savings. You're supposed to have some money in case something happens. The insurance companies are supposed to have that too. But basically, and the Department of Financial Services is supposed to set that amount. So they screwed up. They did not have enough money in this case, and they lost like $1 billion. That's a lot of money, right? Yeah. That's not like losing, $500,000, which companies can absorb that. Like a big company like Westchester Medical can absorb a loss of $500,000. They won't want to. Virtually no company can absorb $1 billion loss.
So it seems, it's a great analysis.
Oh, thank you.
So it seems when people read these results, it puts even more importance on contracting, networking, and so forth.
Yeah.
So you envision that in the future, the company is going to invest even more on the negotiation side and find other means with data or any other means, what have you, to become more successful on the networking side.
Maybe. I say maybe because, so I have a broader theory on this, which is that the Medicaid plans have been really, really successful in this. And it's because they came to the table, and the commercial plans, excuse me, have not been successful in this. And it's because the Medicaid plan goes to a PCP's office, and their Medicaid, basically they have a contract already written that says $70 a visit. Blue Cross goes to the office, and they already have a contract written that says $110 a visit, right? Because one's a commercial plan, one's a Medicaid plan. So they go to the office and they say, we want to negotiate this new exchange plan. And the doctor's office says, okay, well, you had a $70 one written in. Let's do, that's $75 sound. Blue Cross comes to the office and they say, well, you already had $110. Let's do a little bit less. Let's say 105. But there's still a gap, even though they're providing the same services in the same market. So I am of the belief that, and that is like, economists would call that like irrational. Like that is not, what I just said that I believe happens is not supposed to happen in the market. So we'll see if I can come up with a paper that proves that's happening, but that is not supposed to happen. But I believe that that's happening.
Well, the Medicaid side is huge market, right? I mean, you can't really step up
Yes.
the government. The health got to be 105 now.
Well, but in managed care you can. In managed care you can tell health first, no, forget it, and go with Fidelis or go with, right? Because you've got these different private companies that are competing for the business, you actually can do that. When it was just New York State Medicaid in 2010, you couldn't. But now you can.
President Block.
Yeah.
President Block, I really like this presentation, but what I'm really interested in is at what point did they find risk adjustment to be like considered to be the problem? Because you had those two CEOs saying that risk adjustment might have been, something that's causing the problem, or it might be the core of the problem. What I'm thinking is, at what point did they realize that? Because if you're building something, especially an individual market like such as this, you're thinking, what is it that I have to do to not fail? Oh, right?
Yeah.
Exactly. So at what point did this risk adjustment program seems to be the downfall?
So risk adjustment is tricky. First,
Yeah.
And I come from a side where, a lot of the people that I, came up working with, they build these risk adjustment models. That is their job, right? And they're not aiming to come up with a model that is not fair, but a lot of these things are gameable, right? So, you can see Schlosser, who's the CEO of Oscar, so he said, this is June 1st, 2016. He said this 2 years ago. So these guys have known about it for a while. However, if you're a startup, you are basically want to make sure, A, you get enrollment during open enrollment, B, that you price correctly, C, that all your claims are getting paid according to your network, and then at the end, then you're like, oh, I got to do this risk adjustment. And then bam, a year later, you don't find out that what your risk adjustment scores are until a year later. And then a year later is when you get stuck with a bill of $50 million or $100 million.
That seems like.
So United was prepared for this. They knew this. They've been in the business a long time, and they know that, 20% of my 20 cents of the dollar is going to be made up by risk adjustment. So they knew it. Blue Cross knew it. These guys, they might have known it, but they were too worried, just like getting the trains out on time.
So as a startup, could you not find a path to go through one of those companies? One of the companies that's.
So this comes back to what my old boss said, which is, and he does a lot of this work, which is like, they brought a knife to a gunfight, which is that there are companies out there, and I work for Fidelis, I've negotiated with these companies. There are companies out there that will do this risk adjustment stuff for you.
Right.
What I don't understand is, why didn't any of these startups hire one of those companies?
That's where I was going to. Like, how?
I don't know. That is an open question for me, why they didn't do that, because that is the job of these companies. Like, there are these pop-up companies, and their job is to like sift through your coding and say, oh, you could have coded this as a 4, you could have coded this as a 5. I don't know why they didn't do that. That just seems like, they're busy, but the answer is because we're human and they're busy. That's my guess.
Think about why not to fail first, I guess.
Yeah. All right. Thank you.
So moving to the next.
Dr. Adam,
Good job, man.
Thank you.
I have a question, honestly, about that.
Oh, for the,
There were 6 people.
yeah, they could have just shouted out. How do I shut this off?
Am I gonna make everybody die?